Welcome to all those in the U.S. and globally who have joined us today to hear our TAD talk that's talking about dysphagia. And there's been a tremendous amount of interest in this. There's almost 600 participants who have signed up. And I do want to thank those who donated when they signed up and became members. It really helps the foundation with its mission of improving the quality of life for all of those with a swallowing disorder. My name is Ed Steger. I'm president of the foundation, and I'm also a long-term head and neck cancer survivor diagnosed with severe dysphagia in 2007 following a 12-hour salvage surgery where one of the items that was done during that surgery was the severing of my left lingual nerve, and that left me with some speech and swallowing deficits. For those of you who have not joined us before and are unfamiliar with our format, you will be muted during the presentation, but there is a question mark icon, and we encourage you to ask questions at any time. One of the things that makes our TAD Talks different than a more traditional webinar is we've left plenty of time for Q&A because we want to make sure we're addressing your questions. The talk today will be recorded. We recognize that since this is global, times may not work out for everyone, so you will be able to watch this later. There are no ASHA CEUs provided, but we will provide a certificate of participation. I would like to recognize BRACO for their unrestricted educational grant. It helps us deliver this program, and without their support, we would be looking elsewhere. So thank you, BRACO, for providing the funds for this series. And I'd also just like to briefly recognize our other educational sponsors. Again, it all helps. I'm so looking forward to Michelle's talk today. I'm guessing it is why we have so much interest with almost 600 people registered. I live Michelle's topic. I know something is wrong but it can take years to get a diagnosis, if at all. It's frustrating, time-consuming, and filled with anxiety. And I'm not just speaking for myself, but I have a lot of contact within the community, and the number of times I've heard community members say their healthcare providers have told them it's all in their head. Every time I hear that, I cringe. And you know what? It may be in their head, it may not be, but just because the science hasn't quite caught up with what's happening doesn't mean there's not an issue. And with that, it's now my pleasure to introduce speech-language pathologist Michelle Adessa. She has volunteered her time today to share her experience. Michelle, if you want to pop on, that would be great. Michelle is a member of the interdisciplinary care team at the Voice Center at the Cleveland Clinic. She is a former singer and voice teacher. And then in addition to her role at the Cleveland Clinic, Michelle is also a clinical instructor at Case Western, educated residents and medical students on voice and swallowing assessment. Michelle's passionate about helping patients with dysphagia, and we are honored to have her here today. So with that, I'm going to turn this over to Michelle. Our Executive Director, Elizabeth Daly, will help with moderating the Q&A. And again, thanks everyone for joining us. Michelle, it's all yours.
Good morning, everyone. Thank you so much for the opportunity to present on functional swallowing disorders. A special thanks to Elizabeth and Ed for your kind introductions and support, and to the NFOSD for your interest in this topic. And a huge thank you to our Cleveland Clinic multidisciplinary team, including GI psychology, and of course, otolaryngology, as well as our amazing speech pathologists. So let's get into it. So now what? When all the tests are normal, but you still can't swallow. So what do? I have no financial or non-financial disclosures relevant to this presentation. I am a salaried employee of Cleveland Clinic, but that's probably all you need to know. So just to give you a quick overview, we're going to be covering muscle tension dysphagia, a framework for assessment and symptomology, and then looking at treatment paradigms for muscle tension dysphagia. I'll briefly touch on upper airway hypersensitivity and chronic cough, as well as central sensitivity, and then we'll end with a little bit on phagophobia today. So the first thing we're going to talk about is characterizing muscle tension dysphagia and functional dysphagia, because you may have heard this kind of in the ether these past few years. So let's talk about Susie. So Susie can't swallow, and she has been to see everyone. She's had an EGD with gastroenterology. She's had a esophagram. She's had trials of reflux medicine. She's done a manometry study, a pH probe. She's gone over to otolaryngology, and she's had a full workup. She's seen an otolaryngologist and had a flexible laryngoscopy, an MBS. She even had a FEES, and everything is looking good. But Susie still feels like when she's swallowing solids, that there's something that just is sticking. It doesn't feel right in her throat. She feels like there's a lump there. She notices her voice gets hoarse, but she didn't get better with the PPI. So she's had all these normal tests, and she's frustrated and she's anxious because nobody can explain what is wrong with her swallow. So there's a mismatch between her subjective complaint of dysphagia and the instrumental assessment that we normally do for dysphagia. So that begs the question, now what do we do? If we send her away and tell her she's fine, that hasn't really solved the problem. So I'd like to talk about a possibility for Susie that it's perhaps she could have a component of muscle tension dysphagia. This term was codified by the article by Christina Kong, speech pathologist, in 2016 as a new diagnostic term to describe what maybe many of us were actually seeing in the clinic but didn't have a clear way of describing. And so in this original article, she describes both a primary muscle tension dysphagia, which I will refer to as MTDG from henceforth, and then a secondary, muscle tension dysphagia, which is a compensatory muscle tension resulting from a primary problem, whether that be LPRD, whether that be laryngeal hypersensitivity, or various other issues that could arise. And so she described this in the literature, and then in 2023, the AAO put out a best practice statement regarding defining diagnostic criteria for the diagnosis of MTDG. And so there's a strong paradigm here between our patients who have voice and swallowing complaints. So let me just go back a little bit, sorry. Muscle tension dysphonia. So the great majority of patients that I treat are muscle tension dysphonia patients who have voice problems. And so on a flexible laryngoscopy with stroboscopy, we see no organic problems. We see no motion asymmetry, but the patient's voice is still hoarse. So we see this kind of interplay with the same muscles with a different function. So let's go back to this slide, which really gives us an overview and a bird's eye view and best practice for defining what MTDG is. So I just wanted to read from this. This is available on the AAO website. MTDG is currently believed to be a part of a spectrum of disorders known as laryngeal hypersensitivity hyperresponsiveness disorders. These disorders manifest as either sensory or motor abnormalities or a combination of the two. So sometimes it's a little bit complex and may impact any element of laryngeal function, including breathing, voicing, and swallowing. Current research suggests that it is common for patients with LHS, LHR disorders to experience manifestation in more than one laryngeal function at any given time. One recent study by King and colleagues in 2021, which is the subsequent study that she did more on treatment, reported that 65% of MTDG cases were associated with additional laryngeal hypersensitivity above and beyond MTDG. So this establishes a best practice criteria because MTDG is a diagnosis of exclusion, not inclusion. And this is really, really critical because we don't want to be missing things like cancer, like stenosis of the esophagus, achalasia, any issues that could be arising from the esophageal phase of the swallow that could be impacting the sensations in the throat. So this team in the AAO best practice article established a minimum workup required for the diagnosis of MTDG. So we need a clinical swallow eval with a thorough history, which probably goes without saying, but it's good to see this delineated, a laryngoscopic evaluation of the larynx and pharynx, and then instrumental assessment, and the other key piece, an esophageal evaluation. So we would not want to assume that any element is okay without further investigation. So we want to exclude all possibilities of other kinds of dysfunction before landing on MTDG. So there's a great SIG 13 Perspectives article, which I think really sets up this exact thinking and how we think of the swallow really from the lips to the LES. And that this is, we like to say like a unified airway in ENT. And I really think about this as like a unified swallow, meaning all of the elements of one phase may be impacting the other, and we have to thoroughly investigate each phase. And then I think this MTDG diagnosis is a really important step for patients, because as Ed described, they are frustrated, they are anxious because nobody can necessarily explain to them why they're having trouble swallowing. So since 2016, we've seen probably about, I think it's about 12 articles now that have come out. And there's been a couple this year alone. I'd say there's 4 this year alone. These are all on PubMed. I just listed them here for you. So if you just do a quick PubMed search, you'll find these. And in the past year, there's been 4 that came out. So it's definitely something that we're talking about more. And then this last one here, I think, is a really great scoping review that just came out from England. And it's looking at laryngeal hypersensitivity and dysphagia. And so I think it's open access as well. So that one's a good one to read if you want to get kind of a framework for thinking about functional swallowing issues. So what's really interesting is that for speech pathologists who do swallowing, you know, we live in this world and we're always interacting with all these specialties. But I thought this was a really interesting algorithm that I found in a GI journal, and that little red circle is really where SLPs come in. So I think, speaking to the best practice statement, there are so many other things that could go wrong that aren't necessarily something that we are going to be able to treat. But if the patient has throat symptoms resulting from that, that's where we can step in. So let's talk about treatment. Certainly, we don't have a ton of time today to get into all the different treatment modalities, but I wanted to touch on a few so that we could start to have that conversation. So SLP treatment is recommended for both primary and secondary MTDG. And what I think is really important to note is that secondary MTD treatment may be necessary for the resolution of the swallowing problem, even if that primary factor has resolved. So the patient might have severe reflux. They've been taking their PPI, they're feeling great, but they're still having throat symptoms. So treating the primary factor alone doesn't necessarily resolve the swallowing complaint. And we see this all the time in voice. So patients who have vocal fold nodules plus muscle tension dysphonia or vocal fold polyps, or even paresis or paralysis, when we treat the organic or neurological cause of the problem, and that resolves, the patient may still have aberrant muscle patterns impacting their voice. And so what do we do for these patients? So we would assess laryngeal function. I actually palpate almost every patient, and this is beyond the scope of, you know, the entirety of this lecture today, but I take a feel of the neck. I feel the hyoid area, the submental area, the lateral edges of the thyroid cartilage, the SCMs, the upper traps, the scalenes. I look at the lateral and medial movements of the hyolaryngeal complex, the thyroid cartilage, and the hyoid bone. And we're just checking to see if there's anything there that could use manual treatment. The caveat here is that for patients who have sensitivity, they might not do well with this. So some patients, and I would say, you know, this is just my clinical experience here, that most patients tolerate this rather well, with the exception of people who have chronic pain syndromes. And we want to be mindful that if that is something that makes the problem worse, that we don't do it. So it's definitely, I like to take stock of the musculature and then see if there's anything that can be directly treated, and then employing treatment for that, which I will get to on the next slide, but also treatments that we use for voice. And so that includes Lesak-Madsen resonant voice therapy, semi-occluded vocal tract exercises like lip buzzes and straw phonation, and conversational training therapy, which is a Gestalt-based therapy that focuses on clear speech. So what would not be recommended for these patients would be traditional swallowing exercises. So if the system is tense, rigid, inflexible, and we're asking them to strengthen something, I don't suspect that they are going to improve. And I might also add that one other treatment they may be contraindicated is neuromuscular electrical stimulation. So if a patient is tense, we don't want to make them more tense by doing that. So I think let's get down to some of the basics. And I would say that there may be exceptions to those rules, but I would say by and large, these patients don't do well with those two things. So perhaps that begs another question, which is that we should widen the conceptual framework for what we think about with relation to a swallowing problem, and that there's a wider variety of swallowing dysfunction that we can treat as speech pathologists. So we have our hypofunctional patients who may need strengthening and a rigorous boot camp style, let's say a series of exercises. But then there's a group of patients who, on the other hand, are hyperfunctional and they need unloading of the musculature. So I like to think of this work as kind of like you're lifting up the hood of the car and you're looking at all the different parts and seeing where the dysfunction may lie. So kind of like a hyolaryngeal mechanic, if you will. One of the main players in this is the thyrohyoid muscle. And we think of this as an infrahyoid muscle, but for those of us who do voice, we know that this muscle in particular can get very tender. And this is one of the hallmarks of muscle tension dysphonia, or possibly one of the hallmarks. So I like to assess that and see how open the thyrohyoid space is. And this is something that anybody can do. There's I linked the citation here. This new article is great. It has a really great pictures of the anatomy. This is something that I do with many of my voice patients, and then also started working with doing it with my swallowing patients who really didn't have a clear explanation for their swallowing problems. So this is a protocol that I use with my patients. I would say I use the term protocol loosely. It's a series of exercises which I apply as necessary to whatever the dysfunction is. And I also do a variety of other laryngeal manipulations, anterior hyoid stretch, oppositional thyroid cartilage and hyoid bone manipulation. I do myofascial release. And so really personalizing what the patient needs based on their dysfunction. So I also teach this to the patients to do on themselves. And I think that's a really critical piece here, is that we're going to give the patient something to do, that they can be their own therapist, and that they feel reassured that when they feel something, they have something to try to make the swallowing better. So I'm briefly going to touch on chronic cough and upper airway hypersensitivity. So upper airway hypersensitivity has many terms: irritable larynx, laryngeal hyperresponsiveness, which we already discussed. And this can lead to another issue called chronic refractory cough. Chronic refractory cough is a cough that lasts longer than 8 weeks, which defies medical management, meaning it's refractory to the treatment by allergy specialties, reflux treatment, asthma, sinus. So the patient basically can't stop coughing without a clear explanation. Sounds familiar, right? So this slide is a little overwhelming to look at, but what I think is really interesting is when we think about hypersensitivity, there are a lot of mechanisms at play. And we're very focused in our assessments on the motoric elements of swallowing dysfunction. But when we're thinking about patients who may have reactive airways to stimuli or overreactive airways to stimuli, understanding the mechanisms and then helping them understand the mechanisms can be very, very useful for treatment. So we have peripheral nerves, the lining of our mucosa of our throats and our hypopharynx. It's a very sensitive place, as we know, and we want it to be. But for patients who cough a lot, the act of coughing sensitizes the already sensitive nerves of the throat. That in turn sensitizes, the central nervous system. So the upper airway becomes overly sensitized and then starts responding to normal stimuli in the environment: a deep breath, a blast of cold air from the air conditioner, bending over, laying down, or even crunchy tortilla chips, cold popsicles, And patients may complain about swallowing issues, and they may complain of coughing with eating, that when they are assessed on MBS or FEES show normal function. That doesn't mean that every patient who coughs on an MBS or FEES necessarily has chronic refractory cough, because we wouldn't be able to apply that diagnosis unless they've had a full workup. But it's something to keep in mind with what you're seeing. And patients have these paresthesias of the throat, and they have these sensations where they feel something, but there isn't anything there. And the correlate to that, is, if you have diabetic neuropathy, you can get tingling or numbness in your hands or feet. So you can kind of frame it that way for your patients, but the act of coughing sensitizes these nerves. So we do behavioral cough suppression therapy for these patients. And again, a little bit beyond today's lecture, but that we want to dial down that cough sensitivity by using strategies that our larynx and our throat already do. So here are some of the strategies that I would use for chronic refractory cough. I put these here because I think that they are useful for some of our swallowing patients who have muscle tension dysphagia and who have phagophobia. So these will keep the airway nice and relaxed, nice and open. And in cough, we're using these in response to the stimulus or urge to cough. And what we do is we train these strategies, including some swallowing strategies, which are here. And we do these strategies when the patient isn't symptomatic so that they can apply it to their urge to cough. And so I put these on here because I think this is a related topic, and maybe you're seeing it in your clinical practice. And there's a really great textbook on this, Speech Pathology Management of Chronic Refractory Cough by Ann Vertigan, who's like one of the leaders in the field. So one other thing that I watch with these patients and other patients who have irritable larynx is breath holding. Patients may be concentrating and using a lot of laryngeal tension when they're focused. And also, if they're anxious about their throat problems, they may be stressed or worried and they're holding their breath because they're almost like gripping against the sensations that they feel. So we apply these, like I said, when you're asymptomatic, and then we implement them when the patient is symptomatic. So we practice them, and then we can also use them even if the problem already starts. We're going to jump in with the strategy to try to change what is happening. So that's why I have proactive, retroactive, and interactive. We're going to proactively use the strategy to prevent the problem with cough. We're going to retroactively do the strategy to retrain our brain that we don't need to keep coughing. And we're going to use whatever strategy we can to calm down the throat. So this is specifically related to chronic cough, but I think these strategies are often useful with patients who have laryngeal tension or are afraid to swallow as well. So we may need to phone a friend here because this is complicated. And so we turn to our laryngology colleagues who provide some treatments that can be beneficial, which include superior laryngeal nerve blocks for patients who have chronic cough, but also there's a new article from our group where we looked at application of SLN blocks for non-cough related hypersensitivity and found that it was beneficial for patients. So these are patients who have globus sensation and aberrant feelings in the throat. And that is a lidocaine steroid injection plus or, it's a Kenalog steroid injection plus or minus lidocaine. And it's usually bilateral at where the superior laryngeal nerve enters the larynx, and possibly in a zone where the patient feels triggered as well. Also, our laryngology colleagues and our GI colleagues are often using neuromodulators or neuralgia medications like Neurontin and amitriptyline to decrease that nerve hypersensitivity. So sometimes it's a really big team effort for this. So lastly, I would like to talk a little bit about phagophobia. And this is something that you may be seeing clinically and I think is underdescribed, certainly in our literature. And it is a known swallowing phobia. So it's in the DSM-5 under phobias, and also in the ICD-11 that will be coming out soon, under this diagnostic category of avoidant restrictive food intake disorder. So it's a distinct clinical entity, and it's a team effort to, like many of the things that we treat, it's a team effort. So GI, ENT, psychology or GI psychology, SLP and nutrition are some of the specialties that may be involved. So we want to understand the nature of the fear and then rule out any organic or neurogenic cause and understand any of the contributing factors that may be at play. And I might argue, having worked with some of these patients, that we may also apply a similar primary and secondary paradigm. This is just something that I've seen, that we see patients who have an organic problem and they're treated for that. And let's say their EOE resolves. They've got the all clear from GI, everything looks good. Let's say they have stricture, they've had an esophageal dilation, everything's looking good, but they have still developed fear around the sensations of swallowing. And so this becomes something related to what we call visceral hypersensitivity. And the brain has learned these these sensations are unpleasant. And so it creates symptom anxiety around eating and drinking. And then the patient needs assistance and care to get out of the cycle of symptom anxiety and increase positive experiences around eating and drinking. So these are things that, there's not a lot in the literature about this. There's a few case studies, but I think starting to define this in our field is going to be really helpful for patients. The SLP role for phagophobia. So we are the experts of the anatomy and physiology of swallowing. So I think for patients, they may not understand this, and they may not have had anyone truly explain the oral, pharyngeal, and esophageal phases of the swallow. And so taking the time to go over that so they can correlate their experience with understanding the anatomy and physiology, and education on whether they are at risk for aspiration, because many of them may be afraid that they are going to aspirate. But we can outline for them what are these factors for aspiration risk? Do they have any of them? And let them kind of understand a larger framework for their swallowing issues. I talked a little bit about visceral hypersensitivity. And I think especially with these patients, we really want to take their concerns seriously. And we see a correlate with this in functional dysphonia. You could also call that, the older term is like conversion aphonia or psychogenic dysphonia, where this is a very real problem for the patient. It is very, it's huge in their lives. They're may be self-restricting their diet. They've lost a lot of weight. And the joy of eating and drinking is not there anymore. And that can be very scary for people. So I think taking it seriously and then giving them some practical strategies. So I'm going to share a patient story with you now, and then I'll tell you a little bit more about what I did with this patient. He's lovely. He has not really been eating a solid food for about 3 years.
So tell me again what happened before we ended up seeing each other. They did a bunch of things, right?
Yes, I went through extensive studies, the barium swallowing test. Also,
did you do a modified barium swallow and a barium swallow?
Correct, yes.
Oh, wow, okay.
And also the camera that they put through.
Yeah, endoscopy, EGD.
To check. And again, every patient is different. They have different conditions. But from my perspective, I wanted to be able to see what was happening, because I couldn't find personally a connection between what I was feeling along with what I could see or touch.
And so what did they say after you did all of the tests?
To me, it was difficult, to be honest, because the barium test and everything showed that the condition was way better than what I thought. And that was very shocking to me, because in my mind it was I was feeling generally that I was in danger to swallow and choke, when the baron tells me, no, you are technically fine.
Okay, so I'm just going to play another video where he talks a little bit more about what
So
he's
tell
doing.
me again what happened before we ended up seeing each other. They did a bunch of things, right?
Yes, I went through extensive studies.
Sorry.
The baron swallow.
There we go.
What you said?
Yeah.
Sure. Well, from my perspective, I believe that those who are going through treatment or rehab, we have a good opportunity to share what we're going through, to show others that we're together in this journey, that is real, and that we can help each other pretty much, to those who are even a couple of steps behind me in the treatment.
Yeah.
I believe that.
Yeah.
The same way people have shown me from their experience that things can be done differently, or that they can improve, even though at that moment in time you think it's impossible.
Right.
But it's really not, because I'm doing it right now.
Yeah. What are you having there? That looks delicious.
Some tuna salad after almost 3 years.
3 years. Yeah. So you're enjoying the tuna salad?
Oh,
it's one of your favorites, right?
It really is.
And how long has it been, you said?
Almost 3 years.
Wow. I'm so proud of you.
After being on baby food and liquid supplements to keep me pretty much functional.
Yeah.
But right now I'm doing something that with no further training than following, the steps, and just pretty much having faith on myself.
Yeah. You're doing great. We did some mindfulness breathing. We're doing a little technique called sniff and swallow, just to make sure you're still breathing and coordinating your breath with your swallow. So just chewing as you normally would, and then we're kind of just talking like we would, right? We're just talking like we would during a normal meal, and we're telling your body it's safe to swallow, and kind of just having that, kind of creating some more normalcy, right?
Absolutely.
Right. Yeah. Thanks so much.
No, you're very welcome.
And you just swallowed.
Yes. I wasn't thinking about it.
And you weren't even thinking about it.
I wasn't thinking about it.
Okay, so just for this patient, he'd actually had a thyroidectomy in 2015, and he didn't necessarily have problems then, and then he developed eosinophilic esophagitis in 2021. That resolved. He had empiric dilations of his esophagus, but he was still self-restricting his diet. He just couldn't get out of that pattern, and so we just kept working on it. I mean, I didn't see him for that many sessions, but we worked on just some positive affirmations about swallowing. I'd like to just share the sniff and swallow technique. I kind of think of it as almost like the opposite of a supraglottic swallow, where we want to create, calm, and we're working on flexibility and coordination. So chew, 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 sniff through your nose, look down, and swallow. So you're coordinating that breath with the initiation of the swallow. And I'd like to credit my CFY mentor, Tracy Newman, with that, because she uses that with her patients. So thank you so much for that, Tracy. So lots more to say on this topic, but I know that we have limited time. So I wanted to say thank you again for everyone's interest in this topic. And let's get some questions going.
Thank you, Michelle. This was wonderful. Such great information that you shared. I'll jump right into the questions here. I'll kind of go in the order that they came in. The first one here at the beginning of your presentation, you had mentioned LPRD, and there were just a couple questions about what that is and how that's related.
Yeah. Hold on, let me just take this. I'm just going to take off the screen so I can see everyone, I think. There we go. So LPRD, laryngeal pharyngeal reflux disorder. So we can have GERD and we can have laryngeal pharyngeal reflux disorder, and they can co-occur, but there can also be LPRD without GERD. So those symptoms may, be silent in nature, meaning that we just feel globus or trouble swallowing, but it's related to laryngeal LP, laryngeal pharyngeal reflux disorder. Did I answer the right question? Because there's a bunch of different acronyms. There's LHR and there's a few other ones as well, and laryngeal hypersensitivity as well, LHS. So.
Excellent. Thank you for clarifying on that here. I want to read a comment. It says, so rare to attend a webinar that reflects my current practice so closely. So kudos for presenting on this topic. I think it's important. The question here is, how do you proceed with patients who either refuse to believe that there is a primary muscle tension dysphagia or insist on a primary factor being the issue and not wanting to address the secondary muscle tension dysphagia? And any tips for working with caregivers of people with muscle tension dysphagia who may have cognitive deficits and can't necessarily follow through with their
Yeah, this is a challenge. So I think when working with functional disorders, it's really important to reinforce actually what Ed said, which was it's not in your head. There is a reason that you can't swallow, and we have a greater understanding after doing all of this testing, but I like to kind of call it and challenge them to think about it as like diagnostic therapy. So thinking about the treatment almost being the diagnostic feature. Like if we do this treatment and nothing helps, you know, like if we haven't done that, we haven't turned over every stone. I would also leave it in their hands, because if we empower them to help themselves, it's going to lead to a much better outcome. Because ultimately, if you're teaching them the strategies and the exercises, and you're teaching them the massages and manipulations and things like that, not that we do all of them with every patient, that they're going to be their own therapist, and they're going to be able to treat it themselves without your help, you know. So I think that can be an empowering thing. But I would also put it out there that, and this may sound harsh, but we can't care about our problems more than our patients care about their own problems. So we want to help them, but sometimes people, you know, may not be receptive, and that as long as we know that they're safe, you know, I think that they can circle back around if it's not a good time for therapy. Sometimes it's not a good time for therapy. Maybe they just want to make sure that there's not a problem that's, you know, more serious. But you know, sometimes not every time is a good time for therapy, but you can just reassure them that, like, hey, if you want to come back and work on this, you know, I'm happy to help. And sometimes actually backing off is the way to go, I think, with functional disorders. And then the second one was caregivers of patients with cognitive issues. Yeah, ooh, this is a challenging one. Well, some of the work here is somewhat meta, right? Like we're reflecting on how things make us feel. But maybe for patients who have a functional issue, focusing on the motoric task like SOVT or trills or straw phonation. And if there's a cognitive piece, maybe that meta cognitive work is a challenge for them. I'm assuming here. So if you're the caregiver of somebody who has trouble with that maybe focusing on the activity and making the activity like focusing on the fun part of that. Like some of these exercises are pretty fun and silly, like doing or using a straw, doing those types of things. That could be like a fun thing to do with somebody, that just making sound could be enjoyable. So I think maybe not focusing on like that meta piece, and maybe no massage for them, but finding like one strategy that, like maybe doing straw bubbles in water before they eat, like maybe that's an option. I don't know. I'm thinking off the top of my head.
Excellent. Thanks, Michelle. I appreciate what you said, that we can't care about a patient's problem more than they care about it themselves. And I think that's a great point. I remember, I'll give a shout out to my clinical fellow supervisor, since you did too. We would always start a session asking the patient, what is your goal here? Because a lot of times it was just to make sure they didn't have cancer, right? They're okay living with their voice or swallowing problem. They want to be sure it's cancer. And if that's your goal, Excellent. We don't need to treat their voice problem if that's not their concern. So,
Right.
yep. Excellent. There was a question here about the sniff and then swallow technique that you mentioned. Why the chin down position after the sniff?
Oh, because sometimes I find that patients are actually like kind of lifting their chin. I think that's totally up to you. What my goal with that is that we're not pulling up on the suprahyoids, that we're just keeping them a little released. So if there's tension and hesitation, they're in a more favorable position. So we just don't want to be doing like, because you're already engaging these and they're not as free to initiate the swallow. So it doesn't need to be like a chin tuck. I don't think it needs to be like this, but just making sure they don't have their chin elevated, just to just help with that coordination. If they don't like that, or you don't feel like that's necessary, certainly try in whatever position you feel is helpful for them. I think it gives them something to think about. Now we're all doing this, right? We're all breathing while we're chewing, but giving them something to focus on when they're really focused on like the bad thing that's going to happen, I think gives them more control and gives them something to do that's productive. And then you may need to do some like mindfulness breathing to even get them into the state that they can do those food trials, because if they are in a fight or flight response, their brain is telling them this is dangerous, I can't eat, and we want to have some positive experiences with eating. So we have to get them into the rest and digest state of mind in that parasympathetic state, and that may be 5 to 10 minutes of mindfulness breathing, progressive relaxation, and for some patients they may not need that, but that's just an idea. So
thanks. Is there any type of biofeedback or visual biofeedback that you use with patients that have muscle tension dysphagia or even phagophobia?
Yeah, so I've definitely done, and I'm sorry I didn't put that in the slide set, but I definitely have done therapy with fees. Usually, I'll just have them bring in the scary foods that they want to eat and that they can't if they have phagophobia. For muscle tension, sometimes just seeing the video strobe can be really helpful. And then sometimes if we, if we have to circle back to that, I would say that I tend to use it a little bit more with phagophobia than MTDG, but certainly using fees is a really good way to also show people that they can swallow safely. And then if they're perseverative about a specific element of their swallow, you can bring in that exact thing. Like if it's like, whenever I eat tortilla chips, it's really unpleasant and tortilla chips are my favorite food. So then you can work on showing them what's going on, showing them that something is there or not there. And definitely it's a useful tool for sure. I usually use fees for that.
And along the lines of biofeedback, have you or do you ever use SEMG, so surface electromyography, for patients with muscle tension dysphagia, kind of in the reverse of how it's intended sometimes to be used?
Yeah, absolutely. So, in grad school, I was a GA to this neurologist, and he wrote a paper on SEMG for muscle tension dysphonia. I haven't used it. I'd have to refer to that article and how successful it was at measuring tension. So no, I haven't used it. It's an interesting idea that I've certainly thought about. I tend to be kind of analog with this because when the patient goes home, like they won't have that, but it's definitely a good thing to think about trying. We have, the devices like the mobility device. Like, I certainly pose that question to them, like, hey, can I try this with my muscle tension patients and see if there's a utility for this, So I'd love to look into the literature on that. So like, it's just not at top of mind. But yeah, I think it'd be interesting to look at the MTDG folks on the SEMG and on like the mobility for sure.
That's interesting. I would love to know what the research, if there is any out there.
That's the article that I'm remembering, and they looked at it for measuring tension, but I might be mischaracterizing that, so don't quote me on that one.
Excellent. While we're on the topic of resources, would you be willing to share your reference slide with me that you had at the end of the presentation, and then I'll share them? Perfect.
Yeah, no problem.
Excellent. So we'll send that out when I send out the survey to everybody. Going back a couple questions before, somebody asked, and they might have misheard here, how can you have laryngopharyngeal reflux without GERD, so the gastroesophageal reflux, or can you?
Yes, you can. They are two distinct entities, and you can have one without the other, or you can have both. And then we also have the whole topic of non-acid reflux, which is definitely beyond the scope of this presentation. But yes, so patients can have laryngopharyngeal reflux without gastroesophageal reflux, or they can have GERD without LPRD, and or both. So the symptoms, those could be both treated with a PPI or H2 blocker. And then we also use alginates. I don't know if everybody's familiar with those. There's reflux forme and reflux raft. They are an algae that is just like a little supplement that you take. It's a gel, and it just creates a raft at the lower esophageal sphincter. I kind of call it like a barrier method for reflux, and it prevents the reflux from coming up into the esophagus and then onward to the throat. So I think about this especially, and I didn't cover this in this lecture, but about patients who have laryngospasm, where their larynx closes and they can't breathe, talk, or swallow, and that can be very scary for patients. And so that's just something to be aware of.
Excellent, thank you. Question here, how are you assessing the thyroid-hyoid space?
Yeah, that's a great question. Yeah. So I have, of course, worn a turtleneck today. Could I have worn a worse outfit? So here, I'll show you on my little Larry the Larynx, because it might be easier to see. So thyroid cartilage here. So really, I'm basically trying to find this zone, and I'm assessing the vertical height of it. Is there a space, or is it absent? Because sometimes the hyoid and the thyroid cartilage are basically tethered to each other. And this is very common in MTD, muscle tension dysphonia. So this is one of the hallmarks of muscle tension dysphonia. That's not to say that every patient has an absent thyroid space, but it is one of the hallmarks. So I'm palpating through here. And I would also say, like, don't be afraid to touch the larynx. Certainly don't go beyond what you feel comfortable with. And if that's an area you need extra training in, that totally makes sense. I've been very fortunate that my training, I have always been doing this. So to me, it's just a part of my normal practice. So yeah, I find the thyroid notch, I find this space or lack thereof. And the patients with MTDG may be very tight here. You may not be able to even find it. And they may, they may have a completely absent space. So I'm running my fingers along here. I'm asking, I usually have them rate it on a vocal tract discomfort scale from 0 to 5, 5 being the most. This is in the Lieberman articles. And then I'm assessing, would they benefit from some massage? He only has muscles on one side, sorry. But massage of the muscles back and forth as well. And then just making sure the space is open because this tightness there, I like to say, can masquerade as mucus. So it feels like there's something there, but it's really tension.
Interesting, thanks. There was a slide that you had shared that said traditional swallowing exercises are usually not helpful for people with muscle tension dysphagia. Does that include something like the Shakir and the chin tuck against resistance exercise?
Yes, it does. I might argue that there are exceptions to this rule, but if a patient has the inability to fully access the musculature needed to swallow because it is foreshortened, it is tense, it is rigid, and then you're having them squeeze their submental musculature in order to do this, you might be tightening the very thing that needs to be released. So I would never say 100% of the time, because every once in a while there's somebody who doesn't fit a certain kind of criteria. But I would say by and large, yes, please, we want to unload the tension, not strengthen muscles that are already tense. Now, I would say I have seen one case where I had a patient who, it's an individual case where, she actually was tense but also weak. But I would say I've only seen a couple cases of that with MTDG. I'm not saying that, that isn't possible, certainly. But yeah, we don't want to be tightening something that really needs to be released. So if you take your finger and you like really concentrate and tighten your base of tongue, and you're doing this, and then you can't swallow because your tongue is tight, and then we're actually having you tighten your tongue more, it's contraindicated because it's going to make it worse.
Thank you. I like this next question.
Michelle, just a quick follow-up to that. Have any of your patients used Botox to loosen the muscles?
Yeah, that's a good question. So I'm very much involved with our neurolaryngology practice here. So I do a lot of the EMGs with Botox Clinic. So we tend to do, with laryngology, we will use Botox for refractory patients who have muscle tension dysphonia. I can't think of a patient off the top of my head who has had it for muscle tension dysphagia. I also see patients get CP Botox for the cricopharyngeus in Botox Clinic, but I wouldn't say that it's, something that we widely use at all, but for refractory muscle tension dysphonia, it is something that our doctors may do.
Excellent. Thanks, Ed, for asking that. With the CP muscle, can one voluntarily try to relax that muscle?
Which muscle? I'm sorry, I just didn't hear.
The CP muscle, cricopharyngeus muscle.
Oh, to voluntarily relax the muscle? Well, I know that like vowels and like sustained vowels can increase the duration of opening of the CP muscle. I learned that at DRS this year.
Okay.
So thanks for that. Thanks DRS for that. But that's a good question. I sometimes wonder if patients are actually tight from talking a lot, talking and eating a lot, or they have a job that makes them talk a lot. I don't know about automatically relaxing or voluntarily relaxing the CP, but certainly, because it's in line with the cricothyroid, that you could think about massaging that. A lot of patients actually are quite tight here in this little muscle, like right there. And sometimes that's an area that they rate really highly when I ask them about vocal tract discomfort. So that might be a way to help like facilitate that. Although I don't know if you could like relax it on your own, certainly.
Thank you. I have a great question here. It says, do you have any long-term outcome data as to how these patients fare after therapy and whether one session is usually sufficient or if the symptoms reoccur over time?
Some of those articles looked at outcome measures. So definitely look at some of the ones that I listed there. It's just a PubMed search for muscle tension dysphagia. I do have a data set. In that data set that is unpublished right now, the patients had an average of 3 sessions to resolution. Now, is that a durable duration of benefit? Like, how long did their benefit last? Did they have recurrence? I did not track them over time. So I don't have 6-month, 12-month, 24-month data points, but that is certainly would be a wonderful research goal to do a study with that for sure.
Thank you. I'm going to combine 3 questions here. They're all from patients who have a diagnosed swallowing disorder, and it's kind of the opposite of what the title of your talk is. So when the tests are normal, this is when the tests are abnormal, and so they've identified there is a swallowing disorder, but they can't identify the cause. Then what?
Right. Oh, so they still have the problem, but they don't have an explanation for the problem. Am I understanding that correct?
Like, what's the underlying cause of your dysphagia?
Yeah, and so that can be incredibly frustrating. So if they've had the workup that I had at the beginning, and they have not, gotten the answers that they hope to get, sometimes it's worthwhile seeking a second opinion from a particular specialty. Sometimes it may be getting a wider variety of opinions, like including like neurology or something like that. And I think it would be hard to speak to a specific case without knowing that case, of course. But I would say that, certainly not having an explanation to an issue that you're experiencing is very distressing. So certainly if you feel like you need support as you continue to look for answers, and I think you should, I would continue to think out of the box and continue to pursue something to get some answers. And then if you haven't done therapy, you know, for the swallowing problem, finding a therapist that could help. It's hard to be specific without knowing each person's case, but yeah.
Thank you. Yes, and our foundation, we're here to help advocate for those patients, those families that are still looking for referral information.
You know what, one thing I didn't mention, and I should have mentioned, is a wonderful product that I've been using, especially with phagophobia, called Savory's Crispy Melts. So Savory's is a dissolvable solid, so it changes to a puree, and you don't have to chew it, it just dissolves in the mouth, and it's savory. So if you're limiting your diet for safety reasons, you can start to use this, and I use this with my phagophobia patients to chain and link, you know, things that they are comfortable with, so that they can increase their variety of textures and flavors. So it's a nutritive sensory tool to assist with reintroducing textures and flavors, and it's also very safe. So safer than puree, actually. So so that is a tool that I think is super useful. It's called Savory's Crispy Melts, and I think you can just Google that and you can get that product. It's excellent.
Excellent. Thanks for sharing that. I appreciate it. I want to be mindful of the time here. I know a lot of people are at work today. So we will wrap things up, but if there are questions that we didn't get to that you would like an answer to, please feel free to email us and I will forward those on to Michelle. We will provide the reference slide for you. We've also recorded the webinar and we'll make that available on our website in the next 24 hours. But please feel free to reach out if you have any other questions for us. And Michelle, thank you so much for volunteering your time to share this. This was a hot topic and so many questions that have come in. So we really appreciate your expertise on this. Thank you.
Thank you so much for having me today. It's been a pleasure to meet with you all.
Likewise, thanks. All right, goodbye everybody. Hope to see you at our next event.